All right, so it's 8 o'clock. Good morning, everyone. Welcome to CardiOH. Thank you so much for joining us for our Tackling Type 2 Diabetes series. My name's Jessie Lewis. I'll be the clinic coordinator. I know I've talked to many of you via email already. We've got a packed schedule for today to turn it over to our clinic facilitator, Dr. Kathleen Dungan.
Hello, everyone, and welcome to the first session of our ECHO series in tackling type 2 diabetes. My name is Kathleen Dungan. I'm an endocrinologist at The Ohio State University. And before we get started, I'd like to welcome Dr. Donald Wharton, who's Assistant Medical Director of the Ohio Department of Medicaid, to offer a few comments. Dr. Wharton?
Thank you so much, Dr. Dungan. I appreciate it. Let me first just acknowledge the work that you and Dr. Rao have done. This is absolutely outstanding. I know Dr. Mary and I are really excited about some of the work you're doing and some of the outcomes that we're hoping for here. So really, really great stuff. Also, I just wanted to thank Dr. Sherry Bolin for her work with CardiOH in general. I know she's been tireless in these efforts, and I appreciate that. I want to talk just a little bit today about why this is important to the Ohio Department of Medicaid, and perhaps maybe touch on some of the big changes that are going on in Medicaid right now. Those of you who read the paper probably know that we're in the process of something we call Medicaid Reimagined. We are reprocuring all of our managed care organizations. We're moving to a single pharmacy benefit manager. We are working with children with behavioral health needs, specifically with their own managed care organization. And so really, really big changes going on. And certainly during this time of change, the last year has been pretty challenging for most of us. And I think the next year is going to continue to be kind of a period of accelerated change. Just a few of the things that we've seen are increased use of telehealth. We're starting to see quite a bit of hospitals at home. We are beginning to privilege or give privileges to pharmacists. So actually seeing pharmacists kind of evolve into provider status, which is something new as they become part of the care teams that we're doing. We're seeing increased integration with behavioral health specialists. Lots of things going on with this reimagined Medicaid, and one of the things that we're really hoping to do is really continue our focus on chronic disease outcomes. How do we do better with this, with all these new tools, with all these changes, with all of these new levers perhaps that we could pull? And so looking at and participating in programs like this help us kind of navigate that change in the right way. It's, I've heard the term the winds of change. We don't want to just let the winds blow us around. We want to put a rudder down and actually steer a little bit and make sure these changes make sense. And these kinds of programs really help us do that. So I would just encourage everybody who's here today to be active participants, to put your own rudder down, not just be blown around by all these changes, to share your best practices, to disseminate what you learn here, and to really be active and get the most out of this. I think this is a great opportunity. Dr. Mary and I agree that this is definitely worth the investment of time and effort. So with that, I just wanted to say thank you all for coming, and really happy to be part of this program. So thank you very much.
Thank you, Dr. Wharton. So if I could have the next slide. This is the mission of CardiOH, founded just a few years ago. It is to improve cardiovascular and diabetes health outcomes and eliminate disparities. And we do that through a variety of different mechanisms. If you go to our website, you can learn about those mechanisms. And ECHO is just one piece of this this whole initiative. So this is the brief version of the CardioECHO Hub team for today. You'll see that we have different content experts each week. And I would like to have some of the other content experts introduce themselves from week to week. And for now, I'd like Dr. Rao to go ahead and introduce yourself.
Thank you, Kathleen. So I'm Gautam Rao. I'm the director of the CardiO-ECHO program within Cardio, and I'm the chair of the Department of Family Medicine and Community Health at Case Western and University Hospitals. And I'm a health services researcher, primarily focused on management of cardiovascular risks in primary care, especially in young people. And I've been involved in this ECHO program for a couple of years, but in an ECHO program at the University of Chicago for about 10 years now.
Great. And one of our didactic presenters today and content experts throughout this series is Dr. Liz Beverly. Would you like to introduce yourself?
Sure. Hi, I'm Liz Beverly. I am an associate professor of primary care at Ohio University Heritage College of Osteopathic Medicine, and my area of expertise is behavioral diabetes research.
Next slide. And here is a representation of all of you. You can see that we have folks from 15 sites across the state. So we're really excited about this level of participation. And we'll ask each of you as we go through the whole series, when you present a case, to tell us a little bit about your site. So next slide. And then this is the structure of the TeleECHO clinics. So as with today, we'll have a brief introduction, do the roll call, and that'll be followed by a brief didactic presentation. And then we'll have some questions and answers. Following that, we'll have a series of cases. Today, we'll have just one case because we have some introductory elements to accomplish. And then finally, a wrap up. So for the discussion portions of these ECHO clinics, we ask that you please turn on your cameras, and you may unmute yourself and fully participate in the conversation. We very much like to be able to see your faces and talk with you all. If you are unable to do so, or maybe just want to get a quick comment in on the side, feel free to use that chat box as well. But these are meant to be very interactive sessions. And these are our disclosures. You were sent these by email already, I believe yesterday. And with that, I'd like to get started on the didactic portion of this session, which has twofold objectives overall, which is an overview of the 2020 Standards of Medical Care in Diabetes. These have actually just been revised, and so technically now it's the 2020-2021 revisions, as well as the importance of language in diabetes. And so I'm going to ask Dr. Beverly to start first. She's going to be discussing the importance of language. Go ahead, Dr. Beverly.
Thanks, Dr. Dungan. So these are the objectives for this morning. The first objective is what will fall under the importance of language, and that's list and describe the 5 ADA and ADCSE, which is now the new AAD, which is the American Association of Care and Education Specialists, or diabetes educators. And then the other two will fall under Dr. Dungan, which is list criteria for screening, diagnosis of type 2 diabetes, and describe a stepwise progression in management of new onset type 2. So I'm going to be talking about the importance of language in diabetes, and this is a topic that I'm very passionate about. We all know the power of our words, and this is especially true in health, and in this context, it's very important in diabetes. So there's been a lot of research that has documented that there are negative attributions from providers as well as friends and family members towards people with diabetes. And here are just a handful of examples. So if you read the literature, people with diabetes have been referred to as weak, lazy, gluttons, disgusting, poor, bad, and not terribly intelligent. And most of this has come from qualitative research. And so you can see if someone is labeled as any of these adjectives, that can be quite disheartening. And so individuals who perceive this type of stigma, there's been research that shows that people who feel stigma towards their diabetes, and this is type 2 as well as type 1, they also report higher levels of psychological distress. So distress, as well as more depressive symptoms. They also have less social support or perceive less support. And then they also report lower quality of life. And we know from decades of research that people who have psychological distress, depressive symptoms, less social support, and lower quality of life, they also report fewer self-care behaviors. If you perform fewer self-care behaviors, that tends to lead to a higher A1C. And if you have a higher A1C for a prolonged period of time, that leads to increased complications. So you can see that this is a very negative cycle. So back in 2010, Diabetes Australia was the first group to really recognize this connection between stigma and stigma with language, and recognizing the impact that stigma has on not only someone's mental health, but then the consequence of behaviors and diabetes outcomes. They put forward language recommendations. And then this was followed by 2014 with the International Diabetes Federation, and then in 2017 with the ADA and the AADE. Next slide, please. So what I'm going to do is briefly summarize. The ADA and AADE put together a joint recommendation guidelines for language. So you can see here, this is a little bit of a busy table. You can see that there are 5 recommendations that we have for language. The first one being use language that's neutral, non-judgmental, and based on facts, actions, in physiology and biology. So an example, and I've been in the diabetes research world for quite some time, so I can imagine being trained in whatever field that you're coming from. We've been using these terms for a long period of time. If I look back on the research that I've done in the last 10, 15 years, I use terms like poor control and glycemic control. And now we're being told that we need to steer away from those words. So I recognize that this can be quite challenging. So what they're saying as an example of something that is judgmental would be saying, referring to any type of diabetes as its control, or labeling it as good or bad, and even using the term glycemic control. What they're suggesting now, instead of using control, is just saying manage, and just referring outright to someone's numbers, their blood glucose levels or their A1C. So instead of saying that they have poor control or they're trying to achieve control, they're just trying to hit A1C targets or blood glucose targets. The second recommendation is use language that's free from stigma. So 2 of the terms that they have pointed out here are non-compliant, and that's something that's been around for quite some time. So what we're turning to is now referring to engagement and involvement. One thing that's not listed here is the term adherence. So adherence has been readily used for a long time instead of non-compliant, but we're also steering away from that term adherence. This is a tricky one because we're all very used to saying adherence. Engagement doesn't always flow perfectly in a sentence or even when you're writing about it in a paper, but we're all trying to use engagement and involvement because it's a more positive term. Another one, especially when we're talking about type 2 diabetes, is to not refer to it as a lifestyle disease. We know that there are many factors that come into play with the diagnosis of type 2 diabetes, but let's simply refer to it as diabetes. The third language recommendation is to focus on strengths-based, respectful, inclusive language that also imparts hope. And so some of the terms that they referred to is if you're in a medical appointment talking about preventing complications. Instead of that, people who can perform all the self-care behaviors, because it is a chronic progressive condition, you can still perform all of the self-care behaviors and do everything perfectly, but still develop a complication down the line. And so what is best to use is to use the term just reducing your risk of complications. And they're saying that because it can be very disheartening if you're doing everything right and you still develop a complication. And part of that is also because all of the advancements we have in new therapies and new treatments, people are living very long lives with their diabetes. So it's better to say reduce risk. One of the other terms is saying people are refusing to do certain things, refusing to go on insulin. A better thing to refer to that is they're declining. The fourth language recommendation is language that fosters collaboration between patients and providers. I find that regimen is the hardest term that I've been trying to remove from my vocabulary. I'm very used to using the term self-care regimen or treatment regimen. What they recommend saying now is using plan or choice. And that is more of a patient-centered approach to shared decision-making. Another one to steer away from is you can or you can't, but making this more open-ended and saying, would you like to consider such and such for your management? And then the fifth one is, again, focusing on this person-centered care. Rather than referring to someone as diabetic, refer to them as a person who has diabetes. And then saying, what did you do? And when you're meeting with a patient, is just tell me about what you've been doing, and very open-ended rather than placing any form of judgment. So an important consideration with language is to also know that people are very diverse. So what works for one person does not necessarily work for all people. So just an instance is I have a lot of friends who have type 1 diabetes, and I know this is about type 2, but I have a friend who will not consider herself a person, or who considers herself a person with diabetes, while I have another friend who doesn't mind being called diabetic. So it's all about the individual and what their preferences are. And you can't necessarily predict what a person wants. Everyone has different preferences. So the best thing you can do is you can ask a person what their preferences are in terms of language. So this is a very quick recommendation for summaries if you were to swap out some language here. So the terms that I would suggest for skipping, the first one being diabetic, just referring to all people with diabetes. Test, instead of testing someone's numbers, monitoring is the recommended term. Control, removing that from our language, just going with managing their diabetes or managing their A1C. Unrealistic goals, that is a judgmental term. It refers to someone not being able to, or they're not able to hit those goals. So just saying high expectations. Suffering from diabetes, adding that term suffering implies something, and then adding living with diabetes. The good, bad, poor levels, imagine just saying target levels. So again, just simply stating the number. And then the terms to also remove are compliance and adherence. And I will say again, adherence is one of the tougher words to try to remove from your vocabulary, trying to change that to engagement. I would say what I've heard from a lot of people is medication adherence is the most challenging one to remove. So what I have been saying is taking medications. Next slide, please. So the takeaway from this is you don't know what people are going to prefer. You can ask people what they want. So when you're interacting with someone that you know really well, ask them what their preferences are. But if it's the first time you're interacting with someone, just play it very safe and use person first language. So I'm going to turn this over to Dr. Dungan.
Thank you, Liz. That was wonderful. And I concur. I see patients with diabetes every day, and I think it can be very challenging to always use the right words in your speech and in your when you're writing. And it's great to be able to be reminded on a few of those tips of how to manage that. So now I'd like to segue over to our standards of medical care in diabetes. Here is the screening recommendations. These have not changed for some time. Basically, once you're age 45, it's recommended to go through screening every 3 years. And in addition, adults who are overweight or obese who have one or more additional risk factors, I think we're all pretty familiar with these risk factors, should also be screened. And if there is evidence of prediabetes, that screening should be conducted annually. And how should we screen? Again, I think many of us are very familiar with the methods of screening. But keeping in mind that technically you want to have 2 different tests or 2 of the same tests on 2 separate samples that are concordant. So that might mean a fasting glucose of greater than 125 plus an A1C of greater than 6.5, or you might get an A1C on 2 separate occasions that is greater than 6.5. The oral glucose tolerance test is the most sensitive of all of these screening measures, but that is at the expense, of course, of more commitment to time, more blood draws, just more complicated test overall, and slightly less specific. But the diagnosis is greater than 200. Now, in terms of a random glucose, if there are symptoms that are suggestive of diabetes, you're pretty much going to get an A1C anyways. But having those symptoms plus a glucose over 200 is pretty well unequivocal in the absence of other things that might be going on, like use of corticosteroids. And then if someone has prediabetes or maybe has a lot of risk factors, making sure that you refer them or try to manage that with intensive lifestyle interventions. So in particular, in the case of pre-diabetes, particularly if there is impaired glucose tolerance plus impaired fasting glucose, that's the very highest risk group, they should be referred to a diabetes prevention program. So once a person has the diagnosis of diabetes, what do we do next? Well, the next step is to establish an A1C target. In general, most people with new onset diabetes without a lot of other complications or comorbidities we're going to aim for a target of less than 7%. But this is based upon some risk factors that are not modified or characteristics that are not modifiable. And these may develop over time with different treatment therapy, different treatment approaches, including how high is their risk of hypoglycemia, how long have they had diabetes, do they have a short life expectancy, and lots of comorbidities or cardiovascular complications in particular, you might go for a higher target. And then the modifiable risk factors that can change over time. So just considering that because the A1C target 7% now doesn't mean that it will be 5 years from now, and actually vice versa. If there are things in the patient's life that become more stable over time, then that might allow you to tighten the targets. And these are the general recommendations put forth by the ADA. You will see some slight differences in other professional organizations, but in general, they just need to be individualized. In the healthy population, we generally recommend a fasting glucose of 80 to 130 and a peak post-meal glucose 180. In older adults, that needs to be more fine-tuned. And notice we don't say that there's an individual cutoff of age. I think in some cases, age is fairly relative. And if there are other factors like cognitive dysfunction, inability to perform activities of daily living, then you would probably aim for a little bit higher targets of, say, even 8 or 8.5%. And then your glucose monitoring targets would be commensurately higher. That would correspond with that A1C. What about glucose monitoring? Does everybody need to monitor? Not necessarily. So in the case of non-insulin therapies, it can be helpful to perform structured monitoring at various times of the days. I think so often we tend to revert to just fasting glucose measurements. But it should be done in such a way that it's going to be useful to the patient. And even if it's just to assess the initial response to therapy, it may not need to be on an ongoing basis for non-insulin therapies or therapies that don't put a patient at risk for hypoglycemia. And then continuous glucose monitoring can sometimes be considered, but in general, you could think about professional continuous glucose monitoring rather than going through the expense of a actually personal owned device. Now, as regimens get more complex, the recommendations for glucose monitoring should increase with the use of insulin, because that often needs day-to-day adjustments in therapy and recognition that other factors like carbohydrate intake and activity levels, which can affect the need for insulin and or carbohydrates. So with basal insulin 1 to 3 times per day is recommended. For more complex insulin regimens, typically at least 3 times a day, but even above 3 times a day, the more often a patient monitors, the more likely it's going to impact their glucose control. Continuous glucose monitoring in particular has demonstrated the most benefit in persons who are needing more than 1 injection of insulin per day, and in particular those patients who are at highest risk for hypoglycemia or have had previous hypoglycemia. And now I'd like to just provide an overview of the pharmacologic recommendations And it is based upon a very complex image. You can see the entire image in the ADA Standards of Care in 2021. I've simplified it here for you, so we won't have time to really discuss all the nuances. But basically, it's dependent upon whether a patient has cardiovascular disease or renal disease at baseline. And so in this case, you can see in all patients, it's recommended to start metformin plus, very importantly, lifestyle interventions in all patients. If that A1C is 1.5% above target, consider 2-drug therapy to begin. But in the left-hand side of this diagram, if they have atherosclerotic cardiovascular disease, it's recommended that even if their A1C is at target and whether or not they're on metformin, GLP-1 receptor agonist or an SGLT2 inhibitor should be started. And notice it's those medicines that have a proven cardiovascular benefit. And we'll talk about that later in the series. If a patient has heart failure, then an SGLT2 inhibitor with proven cardiovascular benefit in this regard is recommended. And then in the green here, if a patient has kidney disease, so if they have albuminuria, it's recommended that an SGLT2 inhibitor with proven benefit in this regard be started. And if they don't have albuminuria but have CKD, then it's recommended that you use a GLP-1 or an SGLT2 inhibitor because these patients are at higher cardiovascular risk. We don't know if they have microalbuminuria or if they have CKD, if a SGLT2 is better than a GLP-1. That evidence is to come out. And then if that initial therapy doesn't get the patient to target, then you can either add the SGLT2 inhibitor or GLP-1, or you can add any other agent that has demonstrated cardiovascular safety, and those are in this box. So on the other hand, if a patient doesn't have cardiovascular renal disease, then you can consider adding agents based upon other compelling indications. So for hypoglycemia, you would add any of those 4 classes that don't cause hypoglycemia. If you can, you're not going to be able to use a GLP-1 and a DPP-4 inhibitor together because they just don't work well together. They don't provide additional benefit, rather. If weight gain is a major influencing factor, which in most of my patients it is, it's generally suggested to go with a GLP-1 or an SGLT2 inhibitor because those are the 2 drugs that are associated with weight loss. And then finally, if cost is a major factor, then a sulfonylurea or a TZD are generic and could be considered. And then if there are other agents that are needed, you can consider the following in each of those classes. Next. And keep going on based upon the compelling indications above. Next. Okay, so there are a number of different considerations in choosing these treatment classes. Efficacy is one of them. I would say by far and away, insulin is considered the most efficacious. However, in head-to-head studies with GLP-1s, insulin is really at least basal insulin is non-inferior to a GLP-1. Now, when you get more complicated basal bolus regimens, you probably get better A1C lowering with an insulin regimen. However, that is at the expense of additional hypoglycemia and potentially weight gain. There are others, as you can see, that cause differential effects on weight, including TZDs and sulfonylureas. Other side effects that are inherent to each of these drug classes, I won't go into detail, but you can see those there, ranging from gastrointestinal side effects with GLP-1s to the very, very rare risk of lactic acidosis with metformin. Cardiovascular benefit is a strong consideration, as discussed previously on that slide, and then cost. So the newer agents in general are going to be more expensive. Keep in mind that when we consider efficacy, the A1C reduction is dependent upon baseline A1C. So if you're comparing drugs across different studies, if the baseline A1C isn't the same, you're completely, you should not be comparing those 2 drugs. And then also consider that within drug classes, there are differences in weight loss and glucose lowering ability. particularly within the GLP-1s. So those are listed there for you. Next slide. So finally, I just want to present a honed down version of a very important figure that appears in these standards of care, which recommends this patient-centered glycemic management. Like what Liz mentioned earlier, we really want the patient involved with their developing their treatment plan to ensure that it works. Next. So we want to assess what are their specific characteristics that might affect what kinds of treatment they're going to accept and take on a regular basis. Next. We'll consider other factors that might in fact impact their treatment, such as risk of side effects and cost. Next. And then do a shared decision making, really kind of balancing those pros and cons in treatment, and then setting some goals of what that patient and you would like to accomplish. Next, establishing some SMART goals. So again, these should be, very specific goals, not just I want to exercise more. Come up with a plan in an ideal setting. Next. And then reevaluating that plan if needed. The treatment follow-up should be intensified. Diabetes self-management, education, and support is a really important tool for implementing any treatment plan and at very specific time points within a patient's time course of having diabetes. Next. And then establishing that the patient has an ability to maintain this over time, whether that's encouraging them to involve some social support or other kinds of maybe biofeedback, like with counting their steps. Next. And then you're going to just kind of repeat this cycle. All right, next slide. So now I'd like to open this up to conversation. Please go ahead and turn on your cameras if you don't have them on already. And we'd like to kind of discuss things about both of these topics. I guess I will go to the chat box first. Sherry Bolin mentions the VAs using ranges for targets such as goal 7 to 8% as another way to set a target with individuals. Yes, and I think it is just very individuals. Some patients are very happy with getting their A1C from 11 to 9%. That's not to say that we shouldn't, try to, help encourage them, but also recognizing that accomplishment, which may not have been very easy for them. And on the other hand, I have patients who have an A1C of 6% and are upset about that. And it can be very difficult sometimes to try to retrain them, and then just realizing and really trying to minimize any potential for complications. So Liz, I was curious if you could give your thoughts on, that patient who says, I'm just a bad diabetic. So I think there is a long history in some of our patients, and maybe that comes more in patients with type 1 diabetes who've grown up in the 90s and been told, I need to have my blood sugar perfect at all times, even if I have low sugars. How do you handle that?
Well, first, I will disclose that I am not a clinician. I am merely a researcher. I do a lot of qualitative research, so I do hear a lot of stories from individuals, and I think because I'm not clinical, when I do talk to people with diabetes, they do tend to share a lot with me. What I do say, obviously I do disclose to the individual that I'm not clinical, and so they have to talk to their physician or other provider if they want any medical advice. But when I hear these stories about I'm bad or I don't do what I'm supposed to do, I always tell them, I say, diabetes is very, very hard. This is a disease. You have 24 hours a day, 7 days a week. You don't get a break, and it's different for everybody. And I have lots of family members with diabetes, and I have a lot of friends. And that's exactly why I do study diabetes. And so I you know, I tell them some stories about some of my friends and some of their friends' stories, and I share with them what I can without revealing names. And when you share other personal stories and you tell people, it's not easy for anyone. And I think if you give examples about that, and then I quickly just state there's no such thing as someone who's bad. There are people who might be struggling or having a difficult time with their diabetes. And then if they do ask for advice on things that they can do, I just talk to them about, just remember, you just need to focus on small little things. So small changes, and this is where, you know, diabetes educators can be extremely helpful with those SMART goals that you referred to on your presentation. But there's no such thing as someone being bad with their diabetes or labeling themselves at that. I just stress how challenging it is. And sometimes I compare it to other chronic diseases like hypertension, which is something that we focus on so much in cardio. Hypertension is so much easier to manage compared to diabetes, because diabetes affects really every self-care behavior that we do, even if we don't have diabetes. Food and exercise and all of the daily behaviors that we're also expected to do, we add that layer of, if you have diabetes, you have to worry about your food and your carb intake, etc. So I just stress that there really is no such thing as a bad person.
Mhm.
I don't know if that answered your question though.
Yeah. Any other thoughts on that?
Kathleen, I just wanted to get your thoughts, and perhaps anyone else, on clearly the newer agents, GLP-1s and SGLT2s, are very effective, and I found them really effective for my own patients. But just wondering people's thoughts about getting approval and dealing with the enormous cost of some of these medications. Even among our employees here at university hospitals, we've had some changes in coverage of them because they're just so expensive. Anyone have any thoughts on how to overcome that, especially in our Medicaid population?
Mm-hmm. Yeah, interestingly, I found that the Medicaid population is probably easier because it's so predictable, because I know what's on the formulary, and in many ways this can be easier. Anyone else have thoughts on how they try to navigate this?
This is Karen. We enlist we usually have a medical assistant that just specializes in looking for patient assistance programs. And they just have a lot of experience of that. So the provider will just kind of like refer that patient to the MA, and the MA will kind of see what kind of patient assistance programs might be available for the participant. And there's out there's Lilly Cares for insulin, and needy meds, and there's various programs, but often there's someone in the clinic that might be able to help a little bit. So it's nice to have someone that can spend some time doing that. I just wanted to respond to the last comment too. You know, the conversation about people thinking they're a bad diabetic. And one of the things I like everyone to think about is probably your patients are doing something right too, but we tend to be negative and always focus on what we're not doing right. And I think it can be really empowering as a provider just to say, well, you think you're a bad diabetic, and there's just a lot to do when you have diabetes. What are some things you feel like you're doing right? And I think that can really set the stage for feeling a little bit more empowered.
I want to piggyback off of that. Thanks, Karen. You're the person to answer, because Karen's a fantastic diabetes educator here down in Athens, where I am. Karen knows that I do a lot of research, and one of the things I recently just did was talk to people who have diabetes and hear their positive stories, which if you look in the literature, there's nothing about what's positive about diabetes. So it was an interesting study that we just did, and I did it with a student who has diabetes. So I can share that with the group because it's going to be coming out very soon. But it was really interesting when people were finally asked, oh, what was positive, how much they had to say that was positive, because they never thought about it before. And the message was to say, these are all the positive things that can come from diabetes that came from people with diabetes, type 1 and type 2. And the message was to share it with clinicians. So it was just really important to get that information out there. So I do think what Karen said is really important. There are a lot of positives, while we still recognize that diabetes is really hard, and especially if you have social determinants of health, that makes it even harder.
I have a comment about coverage. I'm Pretty Aurora. I'm a family doctor at Community Health Services. Our main clinic is located in Fremont, Ohio, which is about 30 minutes south of Sandusky, and we have satellite offices. So we actually have a program called 340B with the pharmacies. I don't know how we qualify for it or what's the logistic behind it, but a Victoza that would be really expensive in at one of the pharmacies near my office is only $40 for a patient at the pharmacy near our main site. And because only that pharmacy covers or accepts that 340B card. So I have a lot of patients who travel 40 minutes one way to pick up their insulin or their Victoza from that pharmacy. So we are FQHC, so I don't know if that's why we qualify for the 340B program, but that's a really good program. And we also have patient assistance with Lilly. So I have patients on Trulicity through Lilly program as well. So that kind of helps.
Yeah, and there was another comment in the chat that if one is on Medicaid or Medicare, they may not qualify for programs from the drug manufacturer, and that's true. I think even so for Medicare in particular, all those copay cards, they can't use. There are still some indigent programs that are available, but they can be pretty hard to qualify for. And well, it is time now to segue to our case study.
And so at this point, what we generally would do is ask participants if they had any specific questions about the patients. We're not dealing with some of the big issues that I just talked about. Well, the big issue is, how do I prioritize her care in a way that's not overwhelming, but gets her to a place where she's better able to self-manage her diabetes and I'm better able to help her. So I'm going to throw that question out. Does anyone have any questions about this lady herself? So Sherry has a question. Any family involvement and support? Not really. So it's just the patient, her daughter, and the two young children at home. The daughter is, from what I can tell, is either unaware that her mom has diabetes or knows she's had diabetes, but is not at all engaged in this. Any mental health issues? No, absolutely not. Very bright, high school graduate, engaging, certainly engaged in care, and nothing that we could identify. And no, nothing such as depression or anxiety in her history.
I'm curious if there are any support programs of any type or health programs at, for her employer with Amazon.
Yeah, it's a great question, Kathleen. I have not asked that. Does anyone have any awareness? I mean, I don't know, Jim, we've had a number of Amazon employees as well. I don't think they offer much. There's been a lot, not to get too much into this, but I think Amazon really is about completing as much, completing as many packages in a certain amount of time, and you're monitored and videoed, and that's the impression not only she gives me, but some of my other patients give me as well. I don't think they're very engaged in the wellness of their employees, especially now where they're doing so well. They've got so much business there. So a couple other questions. She does not self-monitor. What is her relationship like? I'm sorry, I missed that. What is her relationship like with her daughter and grandchildren? It's apparently fairly good. They seem to have a pretty positive relationship. So though the daughter is not helpful in helping her manage her diabetes, I think they have a good relationship. I get the impression they kind of live separate lives, though. They're just in the same household. It's not like they're having dinner together or anything like that. Can you ask where daughter has obesity or anything concerning about the eating habits of children? My understanding is the daughter does also have obesity. She may want to set an example for them, may help with her eating habits. If you could buy in from the whole family, it might help. And that's a good suggestion as well. So yeah, the daughter has obesity, 2 children do not. Any other questions? Okay, so I guess the question that we can discuss just for a couple of minutes is, she has come in she's getting these refills of metformin somewhere, and that has constituted 100% of care for her diabetes. There really is not a whole lot else going on in terms of her self-care nor her engagement with the healthcare system, but she has health insurance. She's prepared now. She's obviously taken the step to see you and to move in a positive direction. So what might you want to do in the first visit or the first couple of visits? What would be prioritized, do you think?
Well, I think it's always a good idea to kind of find out what her goals are and what she wants to do. And it sounds like she's there for a reason, and maybe getting some idea of where she's coming from.
Yeah, I like that approach. So I don't recall exactly what I did. It's been 7 or 8 months ago, but basically I told her we had done some labs in advance, and that she was not at our goal in terms of diabetes control, that there were better alternatives for improving her diabetes management. And I did ask her what her priorities were. And she was very concerned about the illness overall and preventing complications, because she had heard from friends and other relatives about how severe those could be. That was basically our first visit. I did not put her on insulin. I didn't, put her on an SGLT2 or GLP-1. I did refer her to a certified diabetes educator as well. And I did some education myself. And I asked her to come back and to tell me if her, to kind of do a little teach back about her understanding of what she could do to improve her lifestyle. Then we engaged in mostly lifestyle-based counseling, trying to encourage her to do things that we do in our obesity program: have breakfast every morning, not eat after 7 p.m., avoiding fast food for lunch, engaging in 30 minutes of sustained physical activity apart from her job, which she was not able to do, but she was able to do some of the other things as well. So some suggestions from Pam. I would start with what she's ordering from fast food restaurants. I think just about everything. I'm sorry, it just scrolled up there. A way to foster some motivation. This is Chris Taylor, maybe around the role of the provider she's providing for daughter and grandchildren, is a very good point. And you don't want to scare a patient, but you can ask her, what are your values? You can assume she loves her daughter and her grandchildren very much, and she wants to see them grow up. She's very young. She's got the opportunity to see them to get older and become adults if she wants. And that's something that she would like to do in a healthy state. So that's a really, really good suggestion as well. Karen, discussion and impact of her food choices and lifestyle. Perhaps start with a small goal. Exactly. And the goal we set in terms of lifestyle is just have a healthy, rich breakfast in the morning, so that you're not indulging in Arby's and Wendy's and other places that are easily accessible to her. So she may choose to go there, but hopefully she's not overeating in the daytime. So that was kind of the goal for her at that point. And it's only in the second visit that we started to think about raising her metformin first, and then considering an SGLT2 inhibitor, which she's on right now. But it took a few visits for us to get there. Kay Hoops, I would also hope to emphasize this is a marathon, excellent, not a race mentality. So the advantage we have in primary care is that we have long-term sustained visits, sustained relationships with our patients. And even a specialist like Kathleen also has those relationships as well. So this is not a one and done. Here's what you need to do to fix your diabetes. Thank you very much. Good luck with it, sort of thing. So because we have that long-term relationship, we can tell her that this is going to be a long process. I would often discuss diabetes briefly, but not start. Exactly. That's exactly what I did, which is what Dr. Bola is suggesting. These are the options. These are some of the newer things that are out there. She seemed very overwhelmed by even that small amount of information, so I wasn't about to start them. We can talk about how important it is for her, as Jim is suggesting, to be healthier, to be family related, or about this. My impression with her, I think, is that when she came in, she had very, very little understanding of diabetes complications and improving control. She was thrilled to have regular health insurance, and was probably told by someone, hey, this is something you need to take care of. So she was, she saw this as, hey, this is an opportunity, but didn't know what the opportunity was. What pacing a visit Because she was engaging and motivated, Bridget said monthly. I actually had her come back every couple weeks for the first 2 or 3 visits. I had room on my schedule to do that. And Sherry's saying if we promote monthly, if hemoglobin A1C is greater than that, which is fine. But because she seemed interested, if she wasn't, this is like, I've got to think about this, I'd probably say monthly, but she was ready to do things. She was going to read some of the things I gave her. She was going to see a diabetes educator as well. So I'm going to stop there. Kathleen, great discussion points being raised by everyone, but I hope that gives you a flavor of what a case discussion might be like. I'm going to turn it back to you.
Thank you, Gautam. That was great. And yeah, I agree. It's a great discussion, but we are running short on time. So I would like to now hand this over to Jessie for our wrap up.
Sure. Thanks, Kathleen. Just a few things before we close that we wanted to make you aware of. So first, you will be able to watch this clinic, the recording of this clinic, a little bit later. For this current series, we just ask in order to view the recorded videos, you would have to make an account on our website, cardio.org. So please go there to register. And you can also watch any of our previous TeleECHO clinics as well. And then just a reminder, each week you're going to be receiving a post-clinic survey. This just helps get us a little bit of feedback on today's session. So for today, you should actually already have the survey in your inbox. Please complete that at your earliest convenience. It will be closed tomorrow at 5 p.m. And then last slide, Rick. Just lastly, Cardio is going to be hosting a webinar. It's coming up quickly, February 10th. It'll be from noon to 1. This would be free to attend. CMEs will be available. And the topic is integrating behavioral health and primary care services, lessons learned from 3 Ohio practices. So registration is now open for this event. And again, you can visit our website to fill out a registration form. And with that, I know we're tight on time, so we look forward to next week's talk, which is health literacy and numeracy and its impact on type 2 diabetes. And thanks so much. Have a great rest of your Thursday.
Thanks, everyone. See you next week.
See you next week.